All right, so today we'll talk about knee arthritis. This is a very common problem, especially here in Boca. This is a problem that happens with time. It's associated with wear and tear. So as you get older, your joints start to wear out. It's a mechanical issue, just like your car. More mileage, things start to wear out. So with arthritis, or let's start with the anatomy. Inside the knee, you have the femur, which is the thigh bone. And then you have the tibia, which is your leg bone. And then in between, you have the menisci, which are C-shaped cartilages in between the two bones that act like cushions. So with time, the articular cartilage starts to wear out. You can see here there's different progression or severity of arthritis. So this is a normal knee. This is a slightly advanced arthritis where you can see a little bit of cartilage wear, and then it's progressing. With time, as more cartilage starts to wear out, you start to develop osteophytes, which are on the outside of the bone. This is a way for the body to try and compensate for the decreased surface area that the knee sees to try and disperse the pressure. As the knee wears out with time, not only is the articular cartilage or the surface of the knee joint that wears out, but also the menisci, these two cartilage structures, they also start to wear out with time. It's not uncommon for a patient to show up or a patient to get an MRI for knee pain, and there's a bunch of readings in the setting of arthritis that's positive. For example, advanced cartilage wear, fraying of the ACL, meniscus tears, etc. Patients frequently get focused on one or two different parts of the MRI, and they don't understand, well, why don't you address the knee meniscus problem? And the reason is because the problem isn't the meniscus, the problem is the arthritis. Everything is worn out, so addressing the meniscus with surgery, repairing it, or trimming it out, it doesn't fix the underlying problem, which is wear and tear inside the knee joint. So for that reason, if you have a meniscus tear in the setting of arthritis and there's no mechanical symptoms, your knee doesn't lock up, it doesn't catch, etc., then we don't do surgery to address the meniscus. If you're young, 20 years old, you have trauma to the knee, you have a meniscus tear in the setting of a normal joint, at that point we would be more aggressive as far as treating it surgically to try and fix it. So if that's the case, you have arthritis, you have meniscus tears, that's normal, that happens with arthritis. So the treatment options for arthritis is we start, in general, we start lower on the risk ladder for the treatment options to try and help with the pain that you have with the arthritis. Pain with arthritis fluctuates, it comes and goes. Some people can just say out of the blue, I started having a bunch of knee pain. If I have advanced arthritis, how come my knee wasn't hurting me until today or a week ago? But it could be a bunch of reasons. You increase your activity, weather changes, you tweak your knee. Sometimes we don't even have an explanation. It's just your knee starts hurting in the setting of arthritis. So when you have a flare-up, we do physical therapy. We do anti-inflammatories like ibuprofen, Aleve, naproxen. And if you're still having pain, then we would consider a corticosteroid injection, which is a anti-inflammatory that goes straight inside the knee joint to calm the inflammation down, to help with the pain so you can resume therapy and your normal life. Many times, if this is the first time you're having pain from knee arthritis, these actions are sufficient to reduce the pain to where you can get back to living your normal life. If you do therapy for 2 months, you do injections and anti-inflammatories and you're still having pain, the next step would be viscosupplementation, which are gel shots that goes inside the knee. There's a series, some gel shots are 1, some are 3, some are 5. It all depends on the gel shot from which company it originates from. So that's the next step. If you've tried that, the last option is a knee replacement, which is surgery. You're going in there, cutting off the surface of the arthritic joint. So on the femur, the tibia, and the patella, and you replace it with metal and plastic. That way you're getting rid of all the arthritis and replacing it with artificial implants. The idea or the purpose of this is to help with the arthritic pain that you're having. It's a big surgery, there's risks and complications with the surgery, and it doesn't always fix the pain. 1 out of 5 people, they still have residual problems, the knee doesn't feel right, there's still residual pain, etc. So for that reason, we don't just jump straight to surgery. First of all, is because there's risks, complications happen. Second of all, it doesn't always fix the problem. So if you can address the problem in a lower risk fashion, that's better off. So that's the option. Some patients say they're really apprehensive about surgery. They've tried everything that I've mentioned, and then they ask about biologics such as PRP or stem cells. These are options. It can help with the pain. It's not covered by insurance, so if that's an avenue you like to pursue before trying surgery, that is an option. None of the things that we've mentioned, short of surgery, it changes the arthritis, the surface. It's just surgery. So everything we do is to try and address the pain associated with it. If that's the case, you've tried everything, talk to an orthopedic surgeon, see if you are a candidate for knee replacement surgery. Also, another thing that can be done and is highly encouraged is weight loss. 1 pound of weight is 4 pounds of pressure the knee sees when you're walking. If you're running or jogging, it can be up to 10 pounds of pressure. So every amount of weight in either direction makes a difference on the knee. So for that reason, it is highly encouraged to try and pursue weight loss, activity modifications, and lifestyle changes before undergoing surgery.